Hey everybody, it's Logan Reef here. Just letting everybody know that we are going to have myself, Christine Oakley, and Dr. Nick Schmidlkofer be on the call today. Dr. Nick Schmidlkofer graduated from National a little bit ago, and he has been currently practicing functional neurology at the Neurological Wellness Institute downtown in Chicago. Dr. Nick was an awesome student throughout National. He was a motion palpation president. He ran the functional neurology club, was a tutor for neurology, and I'm sure there's a couple other things in there that I don't fully know what he was doing. But anyways, he's going to be a great person to have on today. He's going to give a good presentation on the vestibular system and how it relates to functional neurology and how he deals with it in his practice. Then hopefully he's going to go over a case or two. And at the end, we're going to have a couple questions for him based off of functional neurology, based off of business, what it was like to be a new professional in the field, kind of his career path, and then maybe just a couple side questions to have some fun at the end. So thanks. Resume recording. Good. So we have Dr. Nick Schmidlkofer here and Christine Oakley on top. And really, Dr. Nick Schmidlkofer is just going to give a little talk presentation to us, but I'm going to let him introduce himself as well. So here you go.
Yeah, so hi, everybody. Basically, my name's Nick. I went to National, I graduated 2 years now, a year and a half ago. And I was an MPI president, MPI rep. And now I'm working in the city. I'm working downtown Chicago, and yeah, I know it's gonna glitch, isn't it? The recording. That's okay. And yeah, working downtown, and I'm working mostly with functional neurology. So I'm seeing patients from post-concussive syndrome or just after concussions, post-TBI, and then also like really strange like dysautonomia patients. So they have temperature regulation, or they stand up and their heart rate rises like 60 points. And then dizziness, vertigo is another big one. So I'll just, let's see if I can do this right. Share my screen here.
Should work.
Yep.
Yep.
Cool. And then I want to do that. Okay, cool. And then so you see my screen. You if you need to like move, the faces around at any time, I think you can do that, right?
Yeah, I think this should be good. I got them in the right, so unless you have anything
yeah, we'll see.
On the right side, we'll see.
Yeah,
I'll move around if there's a picture or something. Perfect.
Okay, so what I'm going to mostly talk about today is just the vestibular system and the importance, because with, let me take a step back. With functionality, like what is functionality? It's not really a profession, it's just a term. And it's a term for us understanding the anatomy of the brain and then how the neurophysiology happens. Like we have so many interactions in our world that are contextual. Like, if you're hungry and you see a donut, you maybe want to just eat that donut. That's a contextual thing. But if that donut's not there, heck, you may not even be hungry. You may be hungry, but then you see water and it's like, oh, maybe I'm thirsty. I'm going to drink something. The brain is getting all these senses all the time through vision, through your touch or proprioception, through hearing. Well, the vestibular system is our most primitive sense. And we are, as in functionality, all it is that we're using evidence-based approaches, whether that be vestibular rehabilitation or ocular motor vision therapy or vagus nerve stimulation or electrical stimulation, breathing, diaphragmatic breathing, yoga. We're using all of these things that are studied, and we're putting it as an approach called functionality, which is basically just a way that we are assessing the brain and then determining how we need to do to change how the brain is bringing in all these contextual stimuli to then have a good output to decrease pain, improve function, all those things. And so the reason why I think every chiropractor should understand the vestibular system is because it is our most primitive sense. The jellyfish had it 6 million years ago, that basically they had to know if they were bobbing up and down or if they were sideways, but they didn't have any kind of smell. They didn't have any other sense except for that they had to know which direction they were going. And so because it's so evolutionarily based, and we had it so long ago in the animal kingdom, it connects to every single part of the body. And I'll show those connections in a sec. So let me just begin here. This is just me. I went to Carthage College in Kenosha. I was a double major in biology and neuroscience. Like I said, I graduated from NUHS in December of 2018, so I guess would have been a year and a half ago. I was a student rep. I was a tutor. I was an anatomy TA, and so now I'm downtown working for the Neurological Wellness Institute. I am a diplomate in the American Chiropractic of Neurology Board, so that diplomate just basically means I have 300 post-grad hours plus I took a test, and that's obviously more chiropractic based, and it's not really recognized by any other profession. So, okay, so dizziness or the vestibular system. Basically, we have, I said we had all these senses. These are our three major senses. There's our vestibular system, our visual system, or coming from our eyes, and then our proprioceptive system. And this is something that, I mean, MPI talks about all the time. We have all of these different senses coming in, and then they have to get coordinated in the central nervous system, integrated to then have proper output. That proper output is going to be good movement and control of movement, but then also our feelings. So like our sensory output of, are we imbalanced? Are we dizzy? Even though this is mostly for dizziness, this picture, it relates to everything. And so I don't know if you know this, but our muscle spindles and joint receptors from our proprioception is actually like 80% of our afferent information coming into our brain. That's because we have so many different muscles in our body. And so that proprioception is a large amount of input, but that's why you can have like vestibular problems and have compensation with your proprioceptive system or your visual system. But then what happens is if you have vestibular issues and then you're compensating with these two, can you see my mouse? Yeah, okay. If you're compensating with the proprioception and the visual system, then all of a sudden, okay, now you get pain. Now you have some sort of, you have a motion restriction. So you have a joint motion restriction between, T1 to T3. And now you're not getting any input into your brain from that region. Well, now you really don't know where your neck is in space. And so the only way to know where your neck is in space is through your visual system, maybe looking at your head in the mirror. And it may cause different postural imbalances with how you hold your head, or if we sit in this, anterior forward head carriage posture. And so this is where a lot of chiropractors, a lot of what we do is working with that proprioceptive system. So we fix the compensatory mechanism. But my approach here is I want everybody to understand the vestibular system a little bit. It will help people, it will help you get people better faster. It will help you be more direct with your approach. And it'll also help, like we say, hold an adjustment. It'll basically help people not need an adjustment as long. They'll stay motion fluid without coming back for an adjustment, 3 times a week or 4 times a week, whatever that may be. And of course, they're going to get better faster. They're going to be able to control their body better. So, okay, this is a really cool paper. Again, the whole importance of the vestibular system. So on the left, this is just the paper, the vestibular pathways involved in cognition. And there's basically just saying how there's so many, like the vestibular system is not just your sense of balance. It is involved in the hippocampus, it's involved in memory, and it's involved in spatial awareness. So Again, you guys can see all this on the right?
Yeah.
Hopefully it's good. Okay. So these are just different brain areas that are involved with the vestibular system, okay, and memory. And so this is a soccer example, but I think it relates to everything really well. So up top, we have a part of the brain that is connected with the vestibular system that's involving, is it a self or an object motion? So like, are you moving or is the object moving towards you? You need to know that, because if you're not going to, or in this case, if you're going to head a ball, you need to know the direction that your head's moving towards it, but also the direction of the ball, right? There's a spot of the brain that's specific to object location, so where the ball is on the field. Then the specific area, the PIVC, which is directly related to how you're moving. Are you spinning in a circle? Are you jumping up and down? Whatever that may be. Then you have a specific spot that's not the object moving, but the object, where is the object in relation to my head? There's my mouse. Object in relation to the head. The distance, is it in my peripersonal space, as in I can touch it with a hand, or like if it's a baseball bat, I can touch it, or is it in my extrapersonal space where I can't reach it yet? Then we have the self-object motion or orientation. Okay, so basically connecting all of them together. So me moving with the object moving, and like how far away is that? Okay, this is my favorite, is the head direction cells. And so these are HD, or head direction cells. And basically this is important for like when we walk into a room. For instance, I'm looking at my computer right now, and I have a grid. So in my hippocampus, my memory is set up so I have this grid of the room, and I know that my computer is right in front. I have an apple here to my right. I have my water bottle to my left. And so this sets up my grid. And then there's place cells. The place cells are those specific objects. So my laptop, my apple, my water bottle. Now, if I turn to the side, my grid moves with me. So my grid is now over here, but the place cells didn't move, right? And so basically what that allows us to do is, if we walk into a new room, we are looking at a bunch of different areas so that we can build this sensory representation of that room. And therefore we understand that now when we turn around, we know where the door is. We know where the window is if we have to get away if something happens. And this is all built on our representation of the vestibular system. So the vestibular system is what gives us this grid, this spatial awareness. And the reason why is what we're going to talk about next. But egocentric just means my like self. So an egocentric view is like first person point of view, where you're imagining yourself looking. Versus an allocentric means that you can imagine yourself in a third person point of view, watching yourself on the field necessarily, okay? Those are important, but not for this lecture. Okay, so the peripheral vestibular system. We're gonna get back into that. I just wanted to say like how important it is. So the peripheral vestibular system is going to be, okay, so how much do people know right now? So in neuroanatomy, you learn the semicircular canals, you know like the utricals and saccule, those otoliths, and then you know the cochlea, okay? Okay, thank you. Okay, we're gonna talk about basically the semicircular canals and the otoliths right here, the saccule and the utricle. And then we're gonna talk about just basics of them, okay? And so you learn about the semicircular canals. You have an anterior, a posterior here, and a horizontal. And these are for angular rotation, okay? So basically me rotating my head this way, you rotating my head this way, left and right or side to side, okay? Or if my head stays still and I'm like spinning in a circle, okay? All that is sensing that. Then you have the saccule and utricle. These are more for translation, okay? Forward and back, like driving a car. side to side if you're on the bus or a train when you're facing the side, but they're also for tilt. So basically, if I tilt my head like this, that is going to be sensed by the otolith, or with the otoconia, okay? So what happens here, we're gonna go down to the left part of this picture. And so if we're spinning, let's say we're walking straight or stationary, it's basically translation. The semicircular canals aren't moving, okay? You have this fluid in here, and the fluid doesn't move, so this cupula, this membrane on top, doesn't affect the hair cells, there's no transmission. Basically, the brain is getting no information about any kind of rotation, okay? But now if you start rotating, okay, let's say if we rotate to the left like this girl is doing, then the endolymph is going to move, this fluid in here is going to move, it's going to deflect the cupula, and therefore the cell membrane is going to be depolarized. We're going to get this sense of spinning, okay? And this is the left horizontal canal because you're rotating to the left, okay? On the other hand, if we go over here, the otoconia is this like weighted membrane, this otolithic membrane, that when we tilt our head forward, we are now going to get this forward displacement of the otolith, and this forward displacement is then going to say, hey, we're bending forward, okay? The problem is, let's see if that's the next slide. No, sorry, I threw this together pretty fast, but so we'll get there. The problem is that this forward tilt is not the same, or it can be represented if I am like in a swirly desk chair and I push back really fast. That backwards translation is going to do the same thing as this forward tilt. So what we learned in school is that semicircular canals are only for angular rotation, and otolithic membrane is more for like tilt and translation, so it has to do with gravity. But that's not it. There's so many connections that are involved inside. This is just like the bare bones. This is all we learn about in school. This is all PTs learn about in school. They only learn about the peripheral vestibular system. And I can say that because my new wife is a PT, and she knows that that's all they learn. And so if we understand the connection centrally, then we can understand that there are many disorders, whether that be with pain or function of movement, that that is due to central connections within the brain, okay? So here are the semicircular canals just within the skull, okay? And this is where I wanted to go with that like spatial grid awareness, okay? So it's in the inner ear here. And so again, you have anterior semicircular canal, posterior, and then horizontal is kind of left and right, side to side, okay? And in the skull, they're like that as well. And so these are within our temporal bone, within the petrous ridge of the temporal bone. They are super small, but because they are locked in, they're locked into this bony anatomy, that they don't move, that this sets up like, this is where my head is in space, and that's it. If I move my head, then they're gonna tell me that I'm moving. But this is different than like our eyes in our orbit. And so if we're looking to the left, that's different. Like if we're looking to the left and we see something over there, am I looking to the left, or is my head turned to the right that I'm now looking to the left, right? Your brain doesn't know that unless it has this bare bones foundation of this is where my head is in space. And so if your head is, some people walk around like this, or if our head is chronically in an anterior head carriage, then they're going to set a foundation, vestibular foundation, off this. And therefore, they're not going to be able to move properly without getting back into a proper foundation of where my head is in space. I have patients that come in, which I'm getting to in the next part, that they chronically hold their head like this. And it's like, this is where their vestibular system tells them this is what's normal. This is their foundation they're building off of. And if they try to build off a foundation that's crooked, it's not going to be as good. They can do it, I mean, you have people that compensate all the time, right? We know athletes are great compensators, but if we reset the foundation, everything else becomes better. Okay. So this vestibular, this bony anatomy is super important because it sets our foundation. It sets that grid. Like we can't make our hippocampus, our memory centers can't make the grid of a room unless we know where we are in space and we know where our head is in space first. Okay. And then that goes down to, we have these like head reference frames and eye reference frames and neck reference frames and body reference frames and hand reference frames. And your brain is comparing all these different reference frames together to say, or to easily make something happen, okay? Easily to make movement happen. But it all starts with the vestibular system. So these are just the multitude of connections that the vestibular system connects to everything. It's this, the one on the left, the picture on the left is from the same article I just posted above. But the one on the right is where we're getting most of what we get in school, okay? So don't worry about all like the separate vestibular nuclei. Where's my mouse? Okay, so semicircular canals, utricle and saccule, they're coming into the vestibular nuclei. Let's just group them as one. But they they connect to our eye muscles through our motor nuclei of our eyes, our abducens, trochlear, and oculomotor nuclei. And this allows us to look straight ahead and turn our head. So we have a vestibular ocular reflex. They also connect to the cerebellum, which is important in coordinating and learning, motor learning, all those things. They connect down with our MLF, our descending fibers, which are basically going to our head more for a better posture. So like basically when you are like this, you should feel that you're like this. But the problem is this sensation, the connection of our visual system, our proprioceptive system, and our vestibular system together at these vestibular nuclei where this all matched basically says that, hey, this is normal for me, and this is my normal. And then everything off of that has to come off of that. To put it into perspective, we have people that come in with shoulder pain, and they think it's coming from their shoulder. But we know that a lot of times it can come from their neck. And so, well, let's say if somebody is, okay, let's say right shoulder. So let's say somebody comes in like this. Well, it's like, hey, heck, they might have like I'm going to use the McKenzie term, they might have a posterior derangement, posterolateral derangement, that they have shoulder pain here. Maybe we should fix the neck first. Maybe we should fix this proprioception, this neck reference frame. Fix the neck first to then see, does that shoulder now improve, right? And while you're fixing the neck, maybe you're actually getting some vestibular input as well that you don't even know, but it's just happening, okay? And this is all because we have these connections from the vestibular system down to the those intrinsic neck muscles. And then we also have our extensor ones. So when we're walking in, so we're balanced. So if we're falling over, we can quickly, if we're falling backwards, we're going to quickly activate our anterior chain to pull us back. If we're falling forward, we're going to activate our posterior chain. If we're falling back and to the right, we're going to activate our left quad to pull us back up, right, and our left hip flexor. Okay, and so besides these ones that are more reflexive, we also have the ones on the left, which basically are going to our hippocampus. Helps us with head direction, like I said before. Tell us just where we are in space in general, and then with the cerebellum helping to coordinate everything. If you try to make a movement, your cerebellum needs to know where everything is in space through your eyes, through your proprioception, through your vestibular system, in order to understand what it needs to coordinate. So that's super important. Okay, now this is what I wanted to get to. Tilt versus translation. Okay, so previously I said the semicircular canals are for rotation, okay? And then the otoliths are more your gravity sensors, okay? They are, I am either laying down and that tilt is going backwards, or my head's to the right, tilt's going this way, or I'm translating one direction to the other, okay? Well, how do the otoliths know the difference between tilt or translation? It's completely different. And the only way is to take into account the activity from the semicircular canal. So the semicircular canals are sensing tilt as well, because this right here, when I tilt my head to the right, even though it's a tilt, I'm activating my anterior semicircular canal on the right and my posterior semicircular canal on the right. They're both here going that way, and I'm activating them. And so in order to understand, if I tilt my head this way, my otoconia fall to the right. Or if I translate to the left, my otoconia moves to the right. So now, when my otoconia, sorry, let's go back. So now if I tilt my head to the right, we have a combination of semicircular canal input and otoconia input. And that together into the vestibular system, into the vestibular nuclei, are saying, Nick is tilting his head to the right. Versus here, I have no movement, no input from my canals. And so, therefore, it's just otolithic hairbend. And so, it's basically just a translation. And so that's a little like formula I have here. We're looking at how far are these hairs on the otolith moving, and then we subtract that from the canal signal. If there is no canal signal when I'm translating, well, then it's translation. But if there is a canal signal, well, then I'm just tilting. But what if you do like that? Well, then you have to cancel out a certain amount of hairbend from, or a certain amount of hairbend, and then you cancel out that little bit of tilt. Go ahead. Yeah.
Yeah. That just kind of sparked a question that I want to ask right now instead of later. When it comes to treatment, are you seeing that with whiplash patients? Because they kind of have that effect of not just translation, not just head tilt, but kind of translation and head tilt. Are you seeing something like correlative there, or is it just kind of that happens to be the movement that they get injured in?
No, of course. So, well, the thing with whiplash is, besides just it affecting the neck, we are affecting the brain. Like, every whiplash is going to have a concussive component, right? There's something called a spinal cord concussion, because a concussion is just a damage to the central nervous system, and a spinal cord is part of the central nervous system. And so when you get a concussion, generally it's happening in the brainstem. Right? You have the brain on top, here's the brainstem, and you get this movement, and then there's this twisting and turning, and so these axons get damaged. Well, at the bottom here, you have the spinal cord, and you have the foramen magnum, and so there's still this turning of the spinal cord. And so you can get a concussion that is affecting both the central nervous system brainstem area, but also central nervous system spinal cord. And then, of course, we have proprioception coming in from our neck. And then you actually have the neck component of, man, is there a derangement just from that? Or are they not, do they not have proper movement? Or is their x-ray just, really crappy because they had that much whiplash? So yes, because you have to remember that now I'm talking this in otolith, right? But if to go back to your question there, Logan, so let's say I'm tilting my whole body to the right versus translating my whole body to the right, and my eyes are closed. That is only coming from the vestibular system. But in whiplash, we are getting information from the semicircular canals in this aspect, the otoliths in this aspect, but also my neck's moving. So I'm getting proprioception here as well. And so we know that we're getting a mismatch there, right? And so yes, you can have the actual damage with whiplash, but if we have so much force coming in this way and there's not just a good signal coming in, then there's going to be problems in how they perceive their neck, whether they perceive their neck more in one side or the other.
Got it.
And so that's going back into, like, this would be a whole nother presentation, is looking at the brain in these different reference frames, like eye reference frame looking in a different direction, or head reference frame, or neck reference frame or
Mhm.
body reference frame, head on neck on body, all those things, because it's crazy how many different reference frames there are that the brain needs to correlate. Okay. So did this make sense, right? I don't think I need to go into the tilt translation. Okay. So yeah, tilt translation, canal signal, they all come together into the brainstem, and this gives us a sense of where we are, where our head is in space, all those things. Okay. So now this clinically, how this incorporates is like a head position, head posture. And so let's just look at the left one. So normal posture, head straight up, but we have this like physiological rightward OTR. OTR is just it's an ocular tilt reaction. It's a term that's used by most of the ophthalmologists. But so if we tilt our head to the right, we should get an equal and opposite reaction from our eyes to go this way. That's a vestibular ocular reflex. Okay, pretty simple there. What happens is we see a lot of the times that we have this like pathological OTR, where rather than having, like, we get this head tilt to the right, but rather than having this compensatory reaction, it just stays up like that. And so that is just a mismatch between how the brain is perceiving balance and through that vestibular system, where there is semicircular canal input, ocular input, otolithic input, proprioceptive input. Okay. So if we look at the picture on the right is talking about just kind of this pathway. So we have, here's the otolithic input and the semicircular canal input going into the vestibular nuclei. Remember, we can have lesions, we can have problems in any part of this pathway. And so when we say that there's a problem with the otoliths or problem with the semicircular canals, we're not saying there's something wrong down here unless they have BPPV, unless they have something inherently going on down there. They had a viral infection. It's normally that they have functional integration problems going on here. They had a concussion, so they had some little bit of damage going on through these pathways. And we know that this connection here, if this connection is not working as well as this one, the one on the left is, good 4-lane highway, it's, 294, and on the right here, it's, it's not working as well. It's, Roosevelt Road, and it's jam packed, and it's just not working as good. Then you're going to have this imbalance. And so this, you can see these vestibular imbalances centrally a lot of the times in head position and posture. And if it doesn't come out perfectly, like it doesn't come out like they're clearly like this, or they're slightly like this, or you have them look at your nose and they're like that, or have a slight head tilt up and back, or whatever it may be. If you don't see it, you can always test for it. And that's what I kind of want to get into. So here's like the spatial orientation of the canals. Okay, let's look at the picture on the left first. Actually, no, we'll look at the one on the right. Okay, so they're not perfectly on a 45, but they generally go on a 45-degree angle. The anterior canal kind of sits like this on both sides. The posterior canals go kind of back on both sides, going down. And then the horizontal canals are like straight on the side, okay? They do angle upwards, which you can kind of see by this picture up here, okay? But this is going to allow us to understand where in space we can favor a canal, okay? Remember that if we're perfectly normal, everything is set up perfect, and we're feeling gravity pushing down on us equally on the right, on the left, back, front, okay? But if we have a slight head tilt to the right, well, something is not right, okay? Whether you're not feeling enough gravity on the left, or you're feeling too much gravity on the right, okay? And this is involved. If we have this head tilt to the right, then we have the horizontal canal is slightly activated, the semicircular canals on either side slightly activated, along with the otoliths. And there's this poor integration inside that, okay? Then, okay, this has already gone a little too long, but that's okay. We're almost done. The picture on the left is kind of just a similar aspect. It's just showing you that the posterior canals are kind of down lower than the anterior canals. That's basically it. This one is the cool one. So picture on the left first. If this guy, let's say he's turned his head to the left and then put his head back, okay? Head left and back. And so that is going to activate the left posterior canal. Left posterior canal sits behind the ear. And so if we put the left posterior canal into the plane of midline, so here we're straight, let's put it into the plane of midline and send it back, we're now activating the left posterior canal. Versus the right posterior canal is the picture below. Again, put it into midline and then send it back. If we want to activate more of the right anterior canal, we're going to put it into midline. So we're going to turn the opposite way and put it down. Now we're activating the right anterior and then left anterior. And remember, horizontal is really only side to side. But if we're talking about like testing the vestibular system, a lot of times we'll say like a head tilt is a horizontal canal, even though it's really the combination of the anterior and posterior. So that's where it gets a little crazy. This is how PTs learn about canals in school. We didn't have this luxury, but they have these really cool things that, you know, National could buy and, you know, maybe with the money that we spend, and we could learn how BPV actually is. And so there's little crystals in here, or you can give like endolymph fluid. And so this is how it looks inside the skull. And so we could actually learn about the vestibular system with this. So
Nick, how much do those cost, do you think?
I don't know, but if you go to Google and you type in like learning the vestibular system, canal thing, like so my wife didn't have these, but they made their own. So they had like a little headband, and they had what are the little like wire tubes?
Yeah, any sort of tube.
Yeah, exactly. And they just made their own, like, and then they learned and they practiced on that, and it's just so much, you know, super easy. So, but either way, that's just a cool way there. Okay, so before we go to that, so when we say that we have this pore integration, the canals are setting our grid, okay? And so contextually, we need to find a basic foundation of the vestibular system. And that is a combination of the otolithic input and the semicircular canal input. And so you can test a ton of different things. You can test cerebellum exercise, okay? You can test finger to nose. I like testing convergence of the eyes, making sure they perfectly go in. You can test muscle tone. Okay, so this might get into like AK, I guess. I mean, you can test like muscle strength, but you can also test reflexes, things that we do all the time. You can test reflexes side to side. Let's say they're more, let's say like a 3 on the right and a 2 on the left. Is that because it's a foundational problem with the vestibular system, or is that because that's just how they are? We don't know until we test it. And then you can also test like pinwheel or like a pinprick, like just see if they feel it the same on both sides. Lots of things you can test, and then check the vestibular system to see, is there a foundational problem wrong with this that's causing this objective finding, okay? And so let's use reflexes, for example, okay? Let's say that you have a +3 patellar reflex on the right and a +2 on the left, okay? Is that just how they are, or is there a problem with the vestibular system? Well, we can test these different head positions. So if they're perfectly straight ahead and you test it, now we take their head to the right, test it again. Is it the same? Is it better? Is it worse? Okay, test to the left, same, better, worse. So that'd be right horizontal canal, left horizontal. We can test head back and right, that's right posterior, left posterior, right anterior, and left anterior. Okay, so we test all these different positions. And let's say that so the right was the +3. Let's say that tilting the head to the right made it a +2, but tilting the head to the left made it like a +3, but even more brisk or whatever. Well, hey, this means that a head tilt had something to do with it. This means the vestibular system had something to do with it, or it was neck muscle proprioception had something to do with it, right? Because that's all we moved. And so, well, if one thing made it worse, or more separated from side to side, and the other thing made it better, like more equal, well, then there's probably a vestibular imbalance. And we can use things you learn in like sixth try, maybe, I think. We can use maneuvers for benign positional, benign paroxysmal positional vertigo, BPPV. We can use those maneuvers to help rebalance the vestibular system. And so let's say we said left made it worse, right made it better. Well, maybe they just don't feel their head to the left very well. So we want to place them in that position in the left. We want to work them into that position. We want to show their brain that it's okay to be in that position to the left. And therefore, that makes everything better. So you could even just, maybe they need a CT adjustment right there, right? All you did was just move that way. Maybe you just need to do a bench TM, just do a CT adjustment, and maybe that equals it out, okay? Maybe you need an occiput adjustment, right? Maybe you just need some soft tissue over there, right? We don't know. Now, one way to test that is, check it again when they put their hand right on the CT junction. That's more like what Dr. Tortorella would call like localizing the lesion, right? Localizing the area. So my presence would be, well, I'm going to check the vestibular system first because that's the foundation. And so if this made it worse, this made it better, I'm going to do a positional maneuver with their eyes closed. I'm going to take out their visual system. I'm going to start with their head off to the right when they're laying down. And we're going to do this barbecue roll, right? Just slowly take their head to the right and we go all the way around, okay? And so let me just get into a case and I'll just be very brief. But how this can affect for everybody. And this is more of a dysautonomia case. This patient, 35-year-old male, he had like brain fog, fatigue, disorientation, temperature irregulation, basically like he'd walk out in the cold and then come back inside and his hands wouldn't warm up for like 3 hours. And then he also had neck pain. All this happened after severe muscle cramps. He had 2 episodes, one early in the summer, one later in the fall, and went to the ER. His CPK levels at that time were like severely elevated. The CPK happens like when you take a statin or if they do too hard of a workout and our muscles start dying and start leaking out CPK, right? And then in both episodes, he was dehydrated, he was drinking. The one in fall, he was after a flu and Gardasil vaccine that happened on the same day. So there was clearly something going on with his immune system at the time. And then it was also shown that he was Lyme positive too. So I saw him after the second episode, he wasn't getting better. He was working with the Lyme doctors, working with a bunch of functional medicine people. And he still had all these symptoms and they weren't getting better, okay? This was like 3 or 4 months afterwards. So in the physical exam, I saw that he had a slight head roll like this, slight right roll, okay? He had, this guy, he could not, so we test eye movements and he could not follow a dot. Everything, any kind of like bright light affected him. So he had problems like just holding his eyes to one side. Pursuits, these SWJ is just square wave jerks. So he basically just had like a lot of movements in his pursuits. Basically, he wasn't able to smoothly pursue. The big one is convergence. So convergence, he had failure bilateral. So I came in and his eyes basically went in and then just stayed out, did not come in at all. And this is probably why he was disoriented, right? This convergence mechanism is involved with the midbrain. If you don't know where contextually, right? Peripersonal space is anything I can touch, extrapersonal space is far away. If something is coming in to hit me, I need to know where it is so I can, smack it away, right? It's a bug, right? But if he doesn't know where that is in space, then like driving is going to be hard. Walking around is going to be hard. Just sitting on his phone and scrolling or working is going to be hard, right? So that failure was there. Well, when I did it, and while he was in a right anterior canal position, it was perfect. came in and settled. Perfect. And then left posterior was actually worse. Okay, something to know. OPKs are just red and white lines. We don't need to talk about that. Finger tap, I checked. These weren't the greatest. Finger, nose, finger. His left was poor versus right. And then a pull test. A pull test is basically you stand behind him and you kind of pull real fast and see if they should only take one step or nothing. They should be able to reactively stabilize. And he stepped back one time, but ideally we don't have anything. So I put his head like that again, did it again. And I always try to pull harder just to make sure I'm making it right. And it was perfect, okay? Improved perfectly. So just from this, we know that, let's check the vestibular system. So here it is. We want to make that foundation. So what did I do? I did a modified Epley maneuver. We say modified because we closed the patient's eyes. And so, how do I want to do this? Okay. Yeah, so we rebalance the central vestibular system. We close their eyes. We take them back into what made them worse. So right anterior canal always goes with left posterior. They're opposite. Right posterior with left anterior. So if his right anterior made it better, then I'm going to start him in left posterior, and I'm going to slowly take his head to the right, and then turn him on his side, end with that right anterior down. We kind of talked about sensing gravity. Well, if the right anterior is down, that is then it's most activated. So we want to start in what makes it worse because we want to show the brain, this is okay. This spot back here is okay. And heck, okay, so I did this. After I opened his eyes, we sat him back up. Easily, his convergence came in, it held for like 2 seconds, and then it started to fail. So it's like, hey, there we go. We built that foundation. Now we have to start driving other things, okay? What did I do afterwards? I adjusted occiput on the left, okay, into this left posterior. Where did I have his eyes? I had his eyes looking more in convergence, okay? We did things where we worked on just convergence. And this guy, like, he thought he was healed after 2 days. It was like, he had all these symptoms, and it was just like, everything's back to normal. And now I'm still treating him because he's on antibiotics for the Lyme and other things. So he's seen a lot of other issues with like leg cramping and stuff. But otherwise, like, it's amazing how something so simple can be beneficial. You just have to test it. Okay. I think, yeah. So that's all I have for like the presentation portion. I'll stop sharing. And then if you want to ask questions, that'd be perfect.
Yeah. Well, first off, thank you for the lecture. That was awesome. I want to say something. I know we talked about it once when I was shadowing you, is how similar, I don't want to say it fully, but how similar Mackenzie and functional neuro are in that you're finding a directional preference of
the
body. So just that concept, I guess, of directional preference. I think everything else is pretty different, but it's interesting to see the similarities.
Yeah. Yes, I love that. So it all goes back, something I didn't talk about, which I should have, right? It all goes back to test or audit, right?
Yep.
Test something out and then retest it, okay? And so that's what we're doing, right? If I do the patellar reflex and it's normal, or it's not normal, and then I test it, again, with a different challenge, that's all it is. It's just challenging it. Heck, I could have just, rather than doing this and it made it worse, heck, you can just sit there and mob the CT and mob it for 10 times, check the patellar reflex again. Does it get better? Okay, maybe they need a CT adjustment, right?
Yep.
And so it all goes back to that. And so, yes, there can be directional preference because you have it's the foundation. The vestibular system is that foundation for this spatial direction.
Yeah.
So.
Yeah, it's really interesting how they kind of correlate similarly. But also, Christine, do you have any questions based off the lecture that you want to ask right away, or before we get into these regular questions?
Yeah, I actually was pretty interested in those grid cells. Is there any memory involved with those? If you were to lose your visual fields, how long is that there? I mean, I've done some training before where you had to remember where points were to enable to escape an area, and I couldn't see. But I'm just wondering if those grid cells were still there in some sort of memory.
So what do you mean you couldn't see? What was that? Repeat that.
I was in dunker training, so I was in a helicopter that went into water and flipped upside down. So
Yep.
you have nothing except for knowing where you are in your seat and where the dashboard is, the door is, and how you're trying to escape.
Okay, yeah. So you knew where everything was before going down.
Right.
Yes. Okay. Yep. So you had those, and so you know that helicopter. Every time that you walk back in that helicopter, you're going to like re-solidify those grid cells, right? They're still going to be there, but you're going to be like, oh, hey, I know that helicopter, right? I know this position, right? That's where, if you want to talk about PTSD, that's where that can kind of spark something, right? But yeah, so those grid cells they're there every time, and then every time you get reacquainted to a new environment or a repeat environment, they're going to continually to build. And so this is where like patients with Alzheimer's that are losing the hippocampus, they get lost more. They don't have that spatial memory. They don't have that ability to understand and know new spaces, which is why you have to be careful if you like try to move them to a nursing home or whatever it may be. So yeah, but again, it's all based on the vestibular system. And so we actually do a lot of vestibular therapy for memory patients, for PTSD, for anxiety, for depression, because that vestibular system, like I said, connects everywhere. And so like you can use vestibular rehab for everything. The only thing is you have to understand, like, what are you doing it for, I guess. You have to, yeah, back to the reference frames, full body versus head versus neck, it becomes more challenging. So.
Awesome. Well, I'm going to get into some of these questions. A couple of them you already answered, so I'll just kind of hyperlink to those in the end when I send this all out. But for those who are interested, how would you suggest finding the right people to follow, books to read, seminars to take, and postgraduate certifications to take? And for those who are interested, I mean interested in functional medicine.
Functional neurology?
Yeah, yeah, neurology, sorry.
Okay. Okay, it's really hard. The best thing to do, the best thing I did was shadow. And so you can shadow me downtown, perfect. We have another office in Wooddale, which is like 20 minutes from the school. So it's like super easy, and that's where I started. I started second try, I shadowed like twice, and then a few more in fourth try. And then once I started getting into it, it was like once or twice a week during clinic. And you have to just see, and the doctors are all generally pretty good, and they're gonna teach you some things on the way. But the more you see, the more you learn. It's kind of like in motion palpation, the more you feel, the more people you feel, the better you get, right? The more times that you adjust somebody, the better you're gonna get. And so it's all about observing, and just like we always, I don't know, those E&M courses, it's always like observation, who cares, right? But to be honest, like observation is so much, because you can see so much from head tilts and posture and how they interact with the world, and you can ask them to pick up something, and everything's a little off. And so I think shadowing is huge. That's like the number one. Books are tough, because there's one book on functionality, and it's like a Dr. Beck. I'd never read it, to be honest, but it's, again, functionality, like I said in the beginning, it's not really a field. So we don't have any research studies. We don't have any books. What we do is we take the research studies from vestibular rehab, from concussion rehab, from PT, and all those other things, manual therapy, and then we incorporate that into our assessment. Functionality is more of an assessment tool, and then we use all the other tools that we learned in school or at seminars to get better at that, right? So that's why an adjustment is just a tool in affecting the brain.
Great.
Then articles are another one. Like, you just got to find articles. So read articles, but books aren't going to.
Oh. Good. Kind of spotted out there. You good now?
I didn't hear that last part.
Yeah, I heard the last part on articles, and then it kind of tailed off. Can you hear it? Microphone maybe give out? Or your Speakers? Oh, now you're muted, unmuted.
There, got me?
There you go.
Okay,
Good.
yep, okay. Yeah, just with the articles, just reading articles. And you can get into seminars, but seminars are expensive.
Yeah.
And so the best thing is just the clinical experience. Like find somebody that'll teach you something.
I've always tried to attest it to like a basketball junkie or something. Just be a junkie with whatever you're interested in.
Yeah, of course.
Okay, so we kind of covered what conditions you commonly see, so I'll skip over that question. I'm interested in how your skills of other modalities, I know you took MDT, I know you did a little DNS, a couple other things have aided you while using functional neurology. And then kind of a side question of that, how does functional neurology coincide with MSK dysfunction? I know you see a lot of concussions, POTS syndrome, if I remember correctly, a couple other things. But how about MSK? How about somebody coming in with chronic right hip pain, you know, something along those lines?
Okay, great. So again, with my assessment, functionality is the assessment. And yes, we're assessing eyes and we're assessing different positions. We're looking at the head reference frame, neck reference frame, body as we go. But all these other tools, like for instance, DNS, if I put somebody in a sideline position, I know I'm activating more of the right otolithic system, right, down in that position. And so like I use that. When a lot of, so cerebellum, the cerebellum is our most coordinating system, right? And so if I want to use a proprioceptive tool, whether that be manual therapy and adjustment, DNS, McKenzie would be a manual therapy, right? I can use those things for those aspects, okay? But I'm still going to try to pair them with a vestibular therapy or with an eye movement therapy or something like that. And so I wouldn't say that I use an adjustment on every patient. I'd say I adjust about 80% of my patients. I wouldn't say I use DNS on every patient, but I definitely use breathing on every patient and breathing in different positions. And then MDT, again, like 50% of my patients, I'm using MDT. But now, like if people have neck pain, yeah, they're for sure starting off with retractions and extensions, and we're seeing if that direction works. And that's an exercise that they're going to have at home. Like what's great about those is I can teach them how to do it, and then I can have them go home with it. Well, I can do other things in the office to maybe expedite their treatment, expedite their plan. The second part of that question was what again?
How does functional neurology coincide with like MSK dysfunction? So you kind of got it a little bit there, but.
Exactly. So I had a patient who, she's an older lady. She still did CrossFit. She was like 68 and still did CrossFit. And, but she always had this right-sided pain, right hip pain and right neck. Okay. And so testing everything, she was like she had a vestibular dysfunction for sure. I'm pretty sure, and this was a long time ago. And she had a head tilt to this side with all this there, right? So what I do is I probably rolled her to start, okay, set that foundation, and then I did a ton of MDT for both the neck and the hip. Like she called it shoulder pain, right? And it was like, front of the shoulder. It was a lot of the neck. Once we fixed the neck, I had to clear out the shoulder a little bit. There was some stuff there. But besides doing a lot of MDT for that, I just started with the vestibular foundational aspect, and then I worked on her eyes. And so she had a lot of those like square wave jerks, jittery, going up and down, back and forth. And so we did a lot of like BOR movements, okay? And I gave her different eye exercises that were specific for her to basically calm down that system, right? If your eyes are moving poorly every time you're trying to follow something or turn your head and they're jumping, well, then that's going to tell your brain that something's wrong and that you're moving in a different direction than you should be. That's where that sensory mismatch of the three come in. And so if we can fix the eye movements, which is a vestibular rehab in a sense, then that's going to help relax a lot of the tension that she was getting, along with working on the proprioceptive component with the MDT, right? And then she was also somebody that, like, once I got her to the point, I did, like, I taught her how to do the check get up. She, like, loved it. And so, I mean, she was just, yeah, exactly. Yeah, she was, yeah, exactly. Her biggest goal was to be able to do, like, a pull-up. And so she was able to when she left. So nice. It's pretty cool. Yeah.
Great. Okay, let's see. I got a couple, just briefly, you don't need to go in too much on this one. But I know it's kind of a trigger word for people, and rightfully so. The connection of the gut and the brain, and how is fixing the microbiome in the gut related to brain health, and what are you seeing with leaky gut versus leaky brain, leaky gut? What came first, the chicken or the egg? Just kind of can speak to a little bit about that. Are you guys also working with that in clinic?
Of course, yeah. And if I'm not working with it directly, somebody else is doing, like, the functional medicine side of that, right? When you get a concussion, you're going to get leaky gut, period. It's pretty obvious. And when you get, when you eat something poor and you have leaky gut because you're sensitive to gluten or whatever it may be, you're going to get leaky brain. The tight junctions, the zonulin and occludins, are the same in the gut as they are in the brain. And so there's been proven associations, connections, that people get concussions and then they get food sensitivities to something after that. Because let's say they get concussion and then, the next day they're eating, whatever they normally eat, their bread, and all of a sudden they have a gluten intolerance, after that, or gluten sensitivity, because that leaky gut is now allowing those gluten peptides in, and then your immune system, which is already overreactive because of the inflammation in your brain, is now overreacting to those food sensitivities. And so just by knowing that and talking to patients about that, that's a huge component. Because a lot of times if we're treating a concussion, we have to settle down the inflammation. And if we're continually feeding the inflammation with gluten or whatever it is, we need to work on that. And so, yeah.
Great. Okay, last question on functional neuro, and then we're going to go in a little bit into business, and then my 3 or 4 questions I got for you just for fun. Yep. I've commonly heard from people when they're kind of nervous about functional neurology, whether or not they believe in it, that old phrase. And then also, it's a cool trick, but it doesn't result in, its results don't hold, and patients go back right to the way that they were before. What can you say towards that, and how are you seeing kind of neuroplasticity function in the long term with your patients?
Of course. It's a cool trick. I love it. So it is a cool trick, right? Because it's amazing. Like I said, that guy, like, I put in, but if I would have stopped there, like, he wouldn't have got better. We just set up a foundation, right? And so what's cool about neuroplasticity is we're changing gene expression. And so we can change gene expression quick to have then more neurotransmitters released at that moment. And therefore, having more neurotransmitters released, we are getting better function quickly. But that doesn't sustain unless we get the long-term gene expression changes. And so the only way to build a habit is to do something for 14 days, 14 to 21 days. You do it, and then now you build a new habit, right? That happens in any kind of habit you want to do, whether it's waking up and working out early or whatever it may be. Mm-hmm. And so if, for instance, me training this guy just to follow my finger in towards his nose and get his eyes to come in, we had to, after that foundational component, we had to work on actually doing that. So if it's in the case of the woman I was talking about, we had the foundational component that improved her range of motion. Oh yeah, that's what I did, is we did like shoulder range of motion, and this made it like worse, or sorry, yeah, that made it worse, and this made it like super better. Like that, like she could go up all the way, no pain, anything, right? And so like, yeah, it was a sensory trick. It was a trick where all of a sudden now it's like, man, I feel better. But it didn't last until we continued to work on that neck and other things, right? Mm-hmm. So that's where it's all about, yes, it's a great trick, and it helps people buy in, right? I mean, all my patients buy in when you can get them that quick response. But then it's about going forward and then building on that neuroplasticity. And that's where it truly fixes the problem. When you have like a concussion, what a concussion is a physical brain injury. And so you need physical rehab to activate those connections constantly and to either build new connections or to just activate and get blood flow there, because then you have the little myelin that wrap around. And so that is going to help strengthen the efficiency of those connections. And so by activating those parts of the brain in a coordinated manner, rather than just doing a flying 7 and adjusting everything, right? We're actually working on one side of the body or the other side, or one side of the brain or the other side, because we're just strengthening certain connections. So
great. Awesome. Love that. Yeah, I kind of think the same thing. It's a kind of all of a trick of what we do, but it's continuously using that trick to kind of help people. All right, so these are a couple questions just with business, post-grad, kind of your experience in general. When did you decide you wanted to be a part of the the Neurological Wellness Institute? Yeah, just when did you want to do that?
I'd say like mid-9th try. So obviously I was always thinking about opening up my own. But then you think about then I was like, so I started shadowing more, and I wanted to help people with neurological issues. And for how much I was shadowing and how much I was learning how much equipment you needed, and for me to do this properly, I was like, man, I just want to get started and learn as much as I can about this field. And so if I went on my own, I wouldn't have the equipment. I would still probably be able to learn and work with patients and help them, but I wouldn't learn as much about being a part of a team, right? And my goal is to have my own practice, or to have another Neurological Wellness Institute where I'm from in Wisconsin, but to start with a group of people where I didn't have the burden of the business aspect. I didn't have the burden of trying to find a loan and starting super small. That was huge for me, because then I could just focus on being a good doctor, right? We learn barely anything in school, and then we have to take seminars, and then with patients, we're just trying to work on our skills of patient care. But then there's so much more. It's like, how do you talk to patients? How do you interact with them? There's so much to learn, and every patient's different, and there's no cookie cutter way of doing things. So yeah.
Great. What early struggles did you have in clinic as a young professional doc?
Clinic, or my first year out?
So yeah, in clinic your first year out. So actually working as a doc. Yeah.
Okay. Being too cocky. being too cocky is the first one, right? You think you know it all, and it's because each time you learn something, it's yes, that's the new thing. That's the best thing, and it's going to help this patient, and it might, right? But then it doesn't. And so I would say I'm learning every day, and I'm still oh, I should try that on this patient. And again, test, retest, reliability, right? And it's oh, if it works, great. If it doesn't, it doesn't. But in the beginning, it was all just relatively being too cocky and thinking that you can fix everybody. And I've helped a lot of people, but there are a lot of people that I haven't been able to, right? Or I've been able to help a little bit, but just not able to get them to the point where either I want, or where I said I could maybe get them to, or where they want as well. And then just understanding your skills, because I don't know it all, and I don't have the greatest skills in a lot of things. But understanding your skills and other skills, people around you, so that you can co-manage or talk or learn from other people, and being able to just ask other people questions, because that's huge. It's all about the patient, it's not about you with the patient. It's all for the patient, right? So yeah, those are the big ones.
Yeah, I found it sometimes when I find a symptom of somebody, they're talking to me, I'm like, oh, I know what that is. And I get excited from my own ego experience. I'm like, oh, I learned that in school. I should know how to treat this. And then I forget that they actually have knee pain in front of me. Yeah. and then
the other thing is, how many patients don't want to do their exercises, or don't want to, or do nutrition, or whatever it may be. So you just have to understand which patients, because the amount of times I want to like talk to somebody about nutrition, but like, you know, they're not going to do it. Or I can talk to someone like you about nutrition and just talk, and you'll figure it out and have it. Other ones, it's like, no, you got to print out something and show them step by step, or you just say, I just want you to start by, you know, not eating a bunch of processed food, and let's try to start there, try to minimize that. Then a week later, maybe we go to, okay, let's increase the healthy fats a little bit, or let's increase in protein, whatever it may be, right?
Yeah. Yeah, it's interesting finding out which patients go with what kind of treatment plan. I guess you kind of said it, but a little bit more. Where do you see yourself and your experience at clinic taking you in the next 5 years?
Yeah, so in the next like 2 to 3 years, I'd like to be back in Wisconsin with either my own clinic or a neurologic wellness institute, and working with patients up there, because there is not there's like no functionality, nobody that does any kind of neurological rehab in Wisconsin. It would just be a great fit. So yeah, that's my big goal. So basically I have my own clinic in that sense and going from there. So
great. And then last question on business post-grad, what is one piece of advice you would give to students going through the chiropractic program who are struggling with plans for their future practice? And that being, you know, that person that kind of says, do I want to be an associate? Do I want to run my own business? Do I want to follow a residency plan? All the different worries that we all have, I'm sure, especially as clinic comes approaching and ending for a lot of us.
Of course. I think go with your gut and your heart is the biggest thing. Because yes, I wanted to have my own practice, but then I was like, I don't know if I can do this right now. Like, especially getting out of school, you're already kind of like, you know, burnt out, and it's like then trying to plan to start a practice. You can do it, I mean, but I just didn't feel that energy to do that. And it has to be small, right? It's hard to get loans nowadays, especially now. Especially now. But it's hard to get loans, and especially small business loans. And so it's one of those things that if you have some, you know, money left over, if you're saving up some money, it may help, and you can start, but also like pick a good area, pick an area you want to be in. And so when it comes to that is like, know where you want to live, know where you want to have a family, know where whatever it is, and then go from there. Is there somebody that you trust to work with that you can be an associate? Is there someone that just trusts you enough that you can be an independent contractor and you can still do whatever you want, but and have your own little kind of side business without the big overhead? And then obviously the residency programs are great. I think they're a great fit for a lot of people, but it really depends on where you are in your life with your family and what you want to do. So
yeah, great answer. Okay, now for a couple fun questions. It's pretty quick. You can answer them as short or as long as you so choose. First one is, if you could bring back any scientist from any field, who would it be and why?
That's a tough one.
Yeah, hot spot.
I don't know, maybe just like Charles Darwin, just because, I mean, I'm big into evolution. And so I think that would be, I like looking at evolution, both based on nutrition and obviously how the brain, I just talked about it. So I think that'd be interesting to talk to him about, you know, how he has found all these species and, you know, just his basis for that. So.
Good. Who was the person that influenced your professional career choice the most?
So I was thinking, I knew I wanted to be in healthcare. I was either going to be like a PT or an MD, because that's all I really knew. That was in high school. And a chiropractor came into my health class and talked to me about, basically I thought chiropractors only were treating necks and backs. And I had a shoulder and elbow pain from baseball at the time. And she just brought me up and said, okay, I look here and I look here, and I would test this out. And then we'd probably stabilize here. And I was like, wow, that's interesting. And then so I started researching it more and found nutrition, and I found the broad field that we can get into. And so I decided to be a chiropractor because of her. I just set them. So yeah.
Nice. Yeah, I think we all kind of have that one weird story where a chiro or shadowing a doc has like kind of changed.
And I never went to a chiropractor before I went to school. My first adjustment was at school by a student.
Really?
Yeah.
That's kind of crazy. I didn't know that. A lot of trust for one student, right?
Yeah, and it was a pretty bad adjustment. So
I'm sure it was. It's like when you have somebody work on you. Like,
the worst part about it was that it was an 8th try student in clinic.
Oh yeah.
And it was a bad adjustment. That's what's horrible about it.
It always, yeah, it's amazing. I think that's a whole different conversation if you want to have that later about.
Exactly.
Anyways, I got 2 more. So what is one book that you have read that has changed you for the better?
I'm going to say 2. The first one is The Power of Habit. I just talked about habits, and I think The Power of Habit is a great book because if you want to learn how to change a habit, he talks about how the basal ganglia is involved, and basically it's a habit loop. It's a understanding that every habit, there's a cue, and then you go through the routine, which is the habit, and then you get some sort of reward. All you have to do is change the routine. And if you just figure out like, hey, every time that, you know, I'm hungry, it's like, rather than picking for a Snickers bar, maybe it's just like you drink some water and just see if that calms everything down. And then you get a reward like, hey, I didn't have a Snickers bar, you know, whatever. So Power of Habit, that is a great book. You can listen on Audible too. And then scientific book, I want to go with, man, that's a tough one. Like I'm going through like my bookshelf right now.
Yeah, right.
Okay, I could do 3, but okay. So the neurology book is the brain, not the brain that changes itself. That's the first one. It's the brain's way of healing. Yeah, there it is. There it is. Norman Doidge.
Look at that.
That is a great book.
I've got both of them.
Yeah. So the brain's way of healing is a great book, and it's by an MD. He talks about neuroplasticity, but he has just specific cases, some on pain, some on whatever, Parkinson's, whatever it may be. And so I think that's a pretty good one. Then I have a couple nutrition ones that are good too. But
okay, carnivore diet. I know that's your thing right now.
Yeah, exactly. I have that one.
I've been following that guy. He's pretty interesting. Okay, last question I kind of thought of in the middle of this, so I had to write it down. If there's one mystery of the body that you could solve or at least know the answer to, what would it be? So something that clearly is probably a lot of research going on that we just don't fully understand. I know what mine would be. I'll tell you after this.
I'm gonna say dysautonomia or POTS. I see so many patients, and some are just a little bit, and some are really bad. And that would just be, it'd be a good one that we could just like figure it out and be like, this is the treatment plan, this is how you have to grade it. But everyone's so different. You could do one thing and it's just, it crashes them, and you can do something else that makes them feel great. So yeah. Okay,
great. Yeah, mine would be consciousness. To figure out consciousness. I think that'd be a cool thing to understand. Christine, you got one?
Cure cancer. That would be pretty cool.
Yeah, cancer would be a good one.
I see. You went with the more practical approach, I think.
Yeah. I'm the mother of 2 kids, you know, practical.
Okay. Well, that wraps it up. I want to thank Dr. Nick Schmidlkofer for coming out here. Christine, thanks for joining us as well with your beautiful new baby. Yep. And also congratulations to Dr. Nick here on just getting married.
Thank you.
Thanks everybody for watching. So I'm gonna